Chapter 10, Venipuncture Procedures. In this PowerPoint, we're going to cover the basic venipuncture procedures as performed in class with various types of equipments. We also are going to look at the list of supplies and equipment for a typical venipuncture procedure, the detailed steps in the patient identification process and what to do if the information is missing, rationale for hand hygiene, identify alternative sites for a venipuncture procedure, describe the order of draw for collection tubes, and describe how to react when a patient is fainted or experiences nausea and vomiting or convulsions. We're also going to cover the identifying the most appropriate site for venipuncture in situations when these sites may not be acceptable. There will be a demo of this procedure both in a video format as well as in class. So in blood collection, there's preparation, including hand hygiene and reviewing the lab tests ordered. Then there's prepare the work area. We're going to approach, identify, and register the patient as applicable to the patient setting. Assess patient's physical disposition prior to drawing. Explain the procedure and obtain consent, and answer any questions related to the venipuncture. So we're going to select and prepare equipment and supplies. It's really essential that we wait to select our needle until we look at our patient. This can be found on page 310 in your textbook. We're going to position the patient by the tourniquet and find a puncture site. When we position the patient, this is where doing the interview, finding out has your patient had their blood drawn before, if so, how did it go? If they tell you the patient states that they have fainted from a previous blood draw, we're going to have the patient lay down for the procedure or in a recliner chair. And then if the patient states that they've had no issues, they can go on a traditional draw chair. We're going to choose a venipuncture method. So are we doing a hand draw? Are we doing an arm draw? Are we drawing a capillary sample? Perform the skin or prepare the puncture site. So we're going to clean it with isopropyl alcohol or chlorhexidine. We're going to collect specimens in the appropriate tubes in the correct order on what was presented to us on the requisition. We're going to transport or store the specimens appropriately, assess criteria for specimen recollection or rejection, and prioritize patients and specimen tubes. Was the request stat, timed, or routine? Preparing for the patient encounter, the rationale is to help the healthcare worker mentally focus on the importance of an individual patient and care for that specific venous blood collection. The preparation, we're going to prepare and assemble PPE, so gloves, mask, gown if necessary. Phlebotomy supplies, we need a test requisition and labels, writing pen, appropriate patient information before the patient encounter and prior to venipuncture process. This image shows you as seen on page 313, phlebotomy tray, phlebotomy cart, which would have all our necessary supplies for the procedure. Preparation, we're going to keep the work area or counter space clean and free of debris. Not only does this show that the healthcare worker is mentally focused on the importance of the individual patient and prepare for that specific venous blood collection, it also shows that we maintain a clean work environment, which builds patient confidence as well. So the procedure, we're going to present positive professional appearance and temperament, take deep cleansing breaths before beginning, and focus on the individual patient. We need to put personal stuff aside. We need to present ourselves with a clean coat, scrubs that are not wrinkled. We're going to, for hair longer than shoulder length, we're going to tie it back and having the necessary equipment. If the patient information is incomplete on the requisition, we're going to obtain assistance from the supervisor or nurse before collecting the sample. We'll never decide to complete the missing information after we collect the sample. It needs to be prior to. If there's a sensitivity to latex products, we're going to use nitropolyethylene or other non-latex gloves or use non-latex tourniquets and bandages. Issues in hand hygiene. Choosing a hand hygiene product. We want to determine is it effective against pathogens? Is the product accessible, easy to use with minimal action? Are these issues related to soap dispensers? Practice of topping off partially filled containers can lead to bacterial contamination. Again, on 10/2, procedure 10/2 and 10/1, please review these preparing for the patient encounter, hand hygiene and gloving technique to review. So rationale for hand hygiene and gloving technique: to protect the patient and healthcare worker from exposure to infectious substances and to prevent transmission of infectious agents. We want to remember the use of gloves does not eliminate the need for hand hygiene, nor does hand hygiene eliminate the need for gloves. We will be handling blood products. Even if you're not the technician drawing the patient and you're assisting, you need to wear gloves. Perform hand hygiene before and after each patient. Use new gloves for each patient. We do our hand hygiene before and after and put on our gloves in the patient's presence. If the hands are visibly dirty or contaminated, we're always going to use soap and water. If not visibly soiled, you can use an alcohol-based hand sanitizer and antimicrobial soap and water. It is recommended that after every third patient, we're washing our hands with soap and water. Indications for hand washing and cleansing. We're going to decontaminate and cleanse the hands before and after contact with the patient, blood, or bodily fluids. We're going to cleanse before and after wearing gloves, and cleanse before eating or using a restroom. The antimicrobial wipes are not as effective as an alcohol-based hand rub or antimicrobial soap and water. Please review the clinical alert on page 314. It talks about healthcare workers must be familiar with policies regarding precautions for handling blood and bodily fluids. We're going to go to page 317 in your text, which is going to discuss needle stick injuries occurring due to the CDC, the type and design of needle and device used, recapping needles, transferring bodily fluids between containers, and improper needle disposal. We want to discuss what employees can do to prevent needle stick injuries on page 317 and 318. We would provide 4 examples in class. What I want you independently to think of is 4 examples that you would like to discuss with your peers, either on the discussion board or you can discuss it in your next lab class. Please review those on 10/2, which covers what employees and what employers can do to prevent needle stick injury. The key thing for employees is that we're going to immediately wash the needle stick site if we do become contaminated, and we also need to report it right away. So initial introduction and patient approach, box 10-3 in your textbook. We're going to have students practice the healthcare worker-patient interaction. So I would like you to review this. You will be practicing it in class on a lab day. It's really essential because it allows you to go through the process of approaching and introducing yourself to your patient, as well as completing the phlebotomy introduction and interview chart, which can be found in your lab book. So approaching, assessing, and identifying the patient, look at the physical disposition of the patient. Did they need to adhere to any diets, alcohol, exercise, or smoking regimens? We're also going to look at factors that cause pre-analytical variability, including age, gender, diet, and exercise, blood type, circadian and seasonal rhythms. Oh, I'm sorry, I'm going to go back. We're going to, again, when we ask the patient, have you had your blood drawn before? If so, how'd it go? Will give us if the patient has ever fainted. We're also going to ask if they have any latex sensitivity or adhesive sensitivity, stress, age, arm preference, and weight. All of these physical dispositions will change how we approach our patient. Arm preference will allow us to know which arm we can draw. Also to see to faint. Diet and alcohol and exercise and smoking, again, we need to make sure if they were supposed to abstain from it that they did. And the age of the patient is going to make a real difference on what we choose for our equipment. Factors that cause preanalytical variables include age, gender, diet, and exercise, blood type, circadian and seasonal rhythms, smoking, chewing gum, tobacco, and alcohol intake, what type of medications the patient might be taking, do they have intravenous lines or vascular access devices, menstrual cycle, pregnancy and menopause, and emotional stress, needle phobia, and psychiatric disorders. These are all things that we have no control over, but could a factor in us being able to assess a proper vein or get a quality sample. Figure 10.3 in your book just goes over the different equipment and draw chairs that are available. So the test requisition should contain the patient's ID, name, unique identification, registration number, location, date of birth, and specimen code. The gender, test to be performed, and date and time of collection or status. Is it a stat test? Is it a time test? Is it fasting? The test requisition should contain special precautions. Is the patient a bleeder? Does the patient easily? Do they have a latex sensitivity? Any clinical information we need to know? Source of the specimen, was it urine? Was it blood? Was it capillary, venous? Billing information when appropriate, and diagnostic coding and physician signature. If there is not a diagnostic code on the requisition, we need to obtain it from a nurse. We're going to check the request prior to venipuncture procedure, so we're going to look for discrepancies, duplicates, and missing information. And we're going to follow up on these prior to drawing the patient. Basics of patient identification, so rationale is to use appropriate patient identifiers for blood specimens, thereby promoting patient safety and accuracy of the laboratory testing results. We're going to have the students complete the interview and introduction together with checklist 11 in our lab class to review this. You're going to greet your patient, identify him or herself, and state their department. Indicate the purpose of the encounter and allow the patient a chance to respond to give implied consent via a gesture or note a patient's refusal for the procedure. So we will greet the patient and state that you are a student from Harper College, your first name, and that you are there to draw their blood and get their consent. Most identification process, it's the most crucial responsibility for which a health worker is held accountable. It's the correct patient identification is critical throughout all phases of laboratory testing. The Joint Commission uses at least 2 patient identifiers, neither being the patient's room number, whenever the providing care, treatment, or services. Patient identification process, so the procedures vary slightly depending on the location. Is the patient in an inpatient or outpatient facility? The type of patient, pediatric, adult. Whether the patient is conscious or unconscious, and the available information at the time. Is there an armband or a patient identification such as a driver's license for us to compare it to? Inpatient identification, all patients except those entering the ER must wear an ID armband and bracelet. The armband must have first and last name and designated hospital number. Long-term care facilities or psychiatric units may not require armbands, and the phlebotomist must verify identity with a nurse or provider in charge. Outpatient patient identification. If calling the patient's name from a waiting room, be careful to state only the name and not to reveal any confidential clinical information. Ambulatory patients may take longer to identify, and the patient ID is preferred. Patients who are comatose or semi-conscious, awaken the patient before collecting and verifying patient ID as you can. If the patient is comatose or semi-conscious, a nurse, relative, or friend can identify the patient by providing the patient's name, address, identification number, and/or birth date. We cannot just go solely based on the patient's ID band. We need a second identifier. So we're going to compare that information with requisition labels to confirm identity, and any discrepancies reported to a supervisor. Please be aware that the ID band needs to be present on your patient. It cannot be on the patient's bed or patient's bedside. If it's not attached to the patient, we need to get the nurse to provide us that information. Identification of infants and young children. It's preferable to use the same identification procedure for both children and adults. Nurse and guardian relatives may identify the infant or child by providing the name, address, identification number, and birth date. And the name of the verifier should be documented as well. In an emergency room setting, temporary master identification may be provided until a positive identification can be made. So they would be given a unique ID number that would be used, and when the permanent identification number is assigned, temporary identification number is cross-referenced to a permanent number. Approaching, assessing, and identifying the patient. So high-risk situations would be siblings or twins, newborns, and common names or similar names, multiple patients sharing a common name. New just because they cannot identify themselves. So we have a unique ID number that verifies the patient as well as the parent prior to doing any procedures. Patients with severe burns or in isolation, only circumstances in which a healthcare worker may use a bed-labeled identification tag to confirm identity, because placing it on the patient would be risky. These rare occasions subject to additional institutional policies. When we have patients with common names, we're also going to look at the patient's birthday and also their middle name to help us identify them. Identity errors are preventable. So most identity errors are due to incorrect requisitions, mixed up paperwork, and failure to follow identification procedures. Can be life-threatening to the patient and grounds for legal action against the employer or employer or both. It's grounds for termination from employment as well. It is a zero tolerance. So please make sure that when identifying your patient, that you have the patient state and spell their first and last name and date of birth, and then verify with the labels and requisition you have in hand. Equipment selection and preparation. Discussion review supplies for routine venipuncture. We're going to provide a video for you to view this because we will show you the stuff inside of the lab class. There's the 4-point supply check when we're looking at equipment selection and preparation. So we're going to check expiration dates on all supplies, inspect needle for defective signs, check the needle is securely attached to the holder, and assure needle compatible with the holder. There is expiration dates on the needle itself as well as our test tubes. Figure 10/19 goes over the basic overview of a patient's arm in selecting veins. Please be aware that every arm is going to have a different vein location, direction. No arm's ever the same. Again, the median cubital vein would be our first choice. The cephalic vein on the outer side, thumb side, would be second, and basilic would be last because of the risk of where the artery and nerve sit underneath it. This image can be found on page 333, as well as the image that is shown on page 335. It goes over in detail the various veins and the type of veins that are present in different arms. Please review. Venipuncture site selection. Factors that affect superficial vein characteristics include the weight of the patient, physiological conditions, gender, and physical features such as skin tone and color and wrinkles. Male versus female, it just really depends upon the, is your patient well hydrated as well? Do not think that every patient that presents as obese is going to be challenging. We need to actually physically look at the arm. Please also view the clinical alert on 335 that talks about nerve damage during venipuncture and how to distinguish an artery from a vein. We will be doing a tourniquet lab, which will kind of key in on venipuncture site selection. The venicular area of the arm is the preferred venipuncture site. They are H-shaped or slanted H or N, M-shaped depending on the way the cephalic, median, cubital, and basilic veins are distributed on the arm. Venipuncture site selections, so the veins in the center median of the venicular area are preferred. There's veins in the outer lateral area, edge of the arm, and on the inner side of the venicular area. We're going to discuss locations not to use for venipuncture. This can be found on page 333 in your textbook. And starts on page 330. We're going to not use arms that have IVs in place in both arms. Burnt or scarred areas. Areas with hematoma or bad bruise. Cast on the arms. Thrombosed vein. And a thrombosed vein lacks resistance, so they feel more like a cord and roll easily. Edematous arms, swollen area due to tissue fluid retention. Lumpectomy on a partial or radical mastectomy or on both sides. We want to also avoid veins on the dorsal side of the hand or wrist. Those are acceptable, but on the flip side, the underside, we will not use those. Okay. Some other areas that we would avoid would be the ankle and foot veins, unless you have a doctor's order to perform this particular procedure. So it is really important that we avoid those sites, as well as we want to also be aware of is that when we're drawing veins not to use typically, we won't use the jugular vein. We won't use the veins in the legs. Typically, we stay in the cubital area of the arm. Tools to make difficult veins more prominent is the tourniquet. We're going to position the arm downward, relaxed, using gravity to fill the veins. We're going to warm the puncture site, and you could use a venoscope, AccuVein viewing system, or an ultrasound to help. Please review procedure 10.4, use of the tourniquet and vein palpation prior to your tourniquet lab. Use of the tourniquet and vein palpation assists in vein location, causes the veins to fill with blood, and enables easier blood flow after needle insertion. It's a single use, and we will have a tourniquet video outside of this PowerPoint for you to view. The instructor will go over the step-by-step process of venipuncture technique with butterfly and the Eclipse needle system. There is a separate PowerPoint that says step-by-step pictures that you can view on your own. Please also review the procedure for performing a venipuncture using the evacuated tube system, procedure 10.6 in your textbook, and 10.7. The wean infusion method or butterfly method, this is ideal for patients with small veins, hand or wrist, pediatric and geriatric patients, patients having numerous needle sticks, needles in restrictive positions or patients in restrictive positions, patients who are severely burned, patients with fragile skin or veins, and patients who are specifically requesting it or short-term infusion therapy. You really need to assess your vein prior to selecting this device. It is more expensive to use, and it could, if the vein is too large, this needle's awfully small, could cause hemolysis of your sample. So the rationale, the wean infusion or butterfly needle devices are useful for venipuncture from a smaller veins. Use of the system requires training and practice, and the smaller veins require more care as the site is being selected and prepared. So special considerations only when using the fly needle. The tubing contains air. It will underfill the first evacuated tube by 0.5 mL, thus affecting the additives to blood ratio. So in a case where we draw a light blue top tube, we can fill a red top non-additive tube with prior to any tubes with additives. After the first tube, the order of draw should be the same. So we could also use another blue top tube with the same additive, sodium citrate, to draw prior to just get the air out of the line. So we're going to hold each tube horizontally or slightly down to avoid transfers of additives from one tube to the next. And a small evacuated collection tube should be used with a wean infusion set to avoid collapsing the fragile veins. So typically we opt for the pediatric tube. So the syringe method. It is not routinely used due to safety concerns, cross-contamination of anticoagulants in multiple tubes, use of excessive force to withdraw blood, or potentially clotting the syringe. This is the syringe method. We're going to show you how to use a syringe with a butterfly, which is a different method. It can be useful in special circumstances and the veins collapse easily. Blood withdrawal can be gently controlled. You do need to be trained on this procedure. But again, we will show you the butterfly with syringe as an alternate to this. Venipuncture methods, we're going to discuss failure to collect blood after a puncture. This can be found on page 353 and 354 in your textbook. You can change your needle position slightly. Do not probe around the site. Try to pull gently outward if you think the needle has gone in too far, or push gently forward if you think the needle has not gone far enough. This can be also assessed by gently palpating above the needle to determine where you are in your vein. We can replace the tube with another evacuated tube in case the first one is malfunctioning. That is another way. And if you do not have a successful venipuncture attempt after the first try, check for another site. Do not make more than 2 venipuncture attempts on one patient. Seek out another person supervisor to make an attempt to notify the physician. We're going to cover this in more detail inside Chapter 9. So order of draw, we went over this previously in Chapter 8. This just goes over it again. We're going to perform our blood culture tubes, yellow closure, or blood culture vials first. Coagulation tubes, which is sodium citrate, light blue. Serum tubes with or without the clot activator, or without the gel polymer barrier. These can be glass, non-additive, or plastic. Order of draw, blood collection tubes. So we have heparin tubes, green or green speckled with light green closures. We have EDTA tubes, which is our purple, lavender, pearl, tan, and royal blue. And then we have our glycolic inhibitor tube, which is our gray closure tube with sodium fluoride and potassium oxalate. You can review these again on page 354 and 355. Issues when filling tubes. So there is additive carryover. This is where the additive or anticoagulant in one tube should not come in contact with the multi-sample needle as the tubes are changed. We want to avoid carryover by gently tapping tubes to move the additive to the bottom of the tube prior to using them. And if the anticoagulant is adversely carried into the next tube, it may cause erroneous test results. So for example, if we were to draw an SST gold prior to our light blue, that spray activated clot activator that's present in that SST gold could get into our light blue, therefore causing the tube to clot, which we do not want to happen because we are looking at how the patient clots on their own in our light blue top tube. So venipuncture method. So specimen labels should include the patient's first and last name, patient's unique identification number or birth date and time of the collection, the specimen type. The date and time of collection will be the time after you drew. So let's say I start the procedure at 1:20 and I'm done at 1:25. I would put 1:25 on my test tube. We're going to ID of the person who collected the specimen, which is a 3-block letter system. So your initials, first, middle, and last. If you do not have a middle name, it would be X. A session to be performed is optional. Patient's room number, bed, assignment, or outpatient status is also optional. The specimen should be labeled. Adhesive or barcode labels immediately at the patient's bedside or ambulatory setting prior to leaving the patient. We also want to hold the tube up to have the patient verify it as well before they leave. Specimen identification and labeling. We're going to discuss special considerations when labeling and things to avoid. And this can actually be found on page 358. Tubes should not be pre-labeled because if they are used, they may be erroneously picked up and used for another patient. So we'll never put the label on the tube prior to drawing. The healthcare worker should ensure that all information on the label is correct, complete, before leaving the patient bedside. The date and time are necessary information because the physician needs to know exactly when the specimen was collected. so that they may correlate results with any medication given or with changes in the patient's condition. The healthcare worker's initials are necessary to help clarify questions about the specimen if they arise. In some cases, the orientation of label on the actual tube may be specified because of the automated process and analytical requirements. And if the healthcare worker cannot obtain a specimen, the worker should document the situation, saying they couldn't obtain the sample so that the lab doesn't expect a tube to come downstairs. Other issues affecting venipunctures, we want to take into consideration the coordination of lab requests to reduce duplications. Keep a log of frequency and volume of blood collected. We want to monitor the number of times a patient can be punctured and reduce the volume of blood discarded when using an IV sample. Please also look at the clinical alert on 359. Use once and discard immediately. Other issues affecting venipuncture, we're going to notify laboratory when multiple time tests are ordered in order to delegate staff appropriately. Assessment of stat orders for clinical necessity, and coordination of therapeutic drug monitoring among staff, and awareness of patient transfers to coordinate tests requests. It is essential that we double check on this because the more blood we draw from a patient one given time, we could introduce that iatrogenic anemia. So we want to avoid these in all circumstances. To reduce hematoma complications, hematomas are caused by blood leakage into the tissue. And we're going to discuss how to reduce hematoma complications, and this can be found on page 361 in your textbook. We're going to strive to insert the needle at the correct angle through the upper vein wall, but not through the lower vein wall. When collecting blood in multiple tubes, hold the needle apparatus very steady when changing tubes so the needle does not slip out or completely go through the vein wall. We're going to remove the tourniquet prior to removing the needle from the patient's arm. We're going to use the recommended antecubital veins only and check for a hematoma formation during the procedure. This would be a bubble that's represented above the needle immediately after the needle is withdrawn. We want to avoid causing a bruise in our patients, so these are just some of the methods for helping reduce that. We want to discuss how to avoid specimen hemolysis. On page 361, examples are provided. There are some here. We want to avoid the use of the 25 gauge needle. This is the smallest needle we could absolutely use and is generally used for neonatal babies. We want to avoid tourniquet application longer than 1 minute. After cleaning with alcohol, we want to allow the site to air dry. Some other things to avoid specimen hemolysis. We do not want to collect a blood specimen in the site that has a hematoma. When mixing the blood in the tubes containing additive, we want to do a gentle inversion. We don't want to shake or aggressively mix these samples. Specimen rejection criteria can be reviewed on page 362 and 363. So identity discrepancies between the requisition forms and the labels, so that if they don't match, that would be a reason for specimen rejection. The identity completely lacking or illegible, so we can't read it. Inadequate volume of blood resulting in unacceptable additive to blood ratio, or it's called QNS, quantity not sufficient. The specimen is hemolyzed, the red blood cells have started breaking apart. The specimen is in the wrong collection tube. So an example of this, we got an order for a PT-INR, which should be drawn in a light blue, and we provided them with a lavender top. Specimens were improperly transported, so it stated that the specimen needs to be frozen and arrived at room temperature. Anticoagulant specimens that contain blood clots. The use of outdated equipment, supplies, or reagents. Contaminated specimens, thereby not cleaning the site properly. Patient not adequately instructed about the diet restrictions, so they came in and they were not fasting. And a time sample drawn at the wrong time or with the time recorded incorrectly. These are just some of the patient's specimen rejections, which are all unavoidable. We can follow up on these prior to these becoming an issue. So venipuncture method. So there is, starting on page 363, this is prioritizing patient's specimen collection. So fasting specimen, this requires blood to be taken from a patient who has abstained from eating and drinking anything except for water for a particular period of time, generally 8 to 12 hours. The fasting levels of glucose, cholesterol, and triglycerides are used for diagnosis and monitoring. Documentation must then indicate that the patient is non-fasting because there is a different testing reference range for this. Where a time specimen, blood must be drawn as near to the requested time as possible. Monitoring medications, glucose level, fasting restrictions, or circadian rhythms, and certain natural hormone levels such as cortisol also increase and decrease with the time of day. So we got to keep in mind that we want to make sure that we're drawing those at the appropriate time. This would also fall under our TDM, which is therapeutic drug monitoring. Please review TDM is used for the following reasons on page 363. So again, prioritizing patients, I just started to go over the TDM, helps determine correct dosage, prevent overdose, monitor drug interactions, and helps prevent toxicity in drugs with narrow therapeutic windows. We also have our STAT, or emergency specimens. Patient has a medical condition must be treated or responded to as a medical emergency or health crisis. The specimen must be drawn, delivered to laboratory analysis without delay, generally within 1 hour. Please be aware that in some cases for the fasting sample, the patient's DOR may indicate NPO, meaning nothing by mouth. We need to be mindful of that to make sure that we don't give them anything to eat or drink. They might be getting surgery. So at no time would we ever give a patient something without consulting with the nurse or physician first. The other thing that I want you to review is patient refusal on page 362. And the healthcare worker can explain the following to the patient. Laboratory results are used to help the patient make accurate diagnosis. The laboratory results provide data to establish proper treatment and monitor the patient's health status. The patient's cooperation would be greatly appreciated. If the patient continues to refuse, then the healthcare worker must remain professional and acknowledge the patient's right to refuse. In documentation, the refusal must occur and the patient's physician must be notified. We will have the nurse sign off about that refusal as well. Please also review the study questions, case studies, and action and practice at the end of this chapter to prepare for the lecture, as well as going over the competency assessments, which will be covered in class. Patient identification, preparing for the patient encounter, use of the tourniquet, cleansing the puncture site, performing the venipuncture, order of draw, and leaving the patient. These are all essential. As you will be practicing on artificial arm draws and live draws, you will become acclimated to this procedure very thoroughly. That concludes Chapter 10's narrated PowerPoint. Please also keep in mind there is a second PowerPoint that provides a step-by-step venipuncture images for you to view as well.